Good evening, everyone. These are my disclosures. I thought I would start with the words of a Greek philosopher. I hope to arrive at my death late, in love, and a little drunk. I think for all of us, we want to prolong our life as long as possible and when we're feeling healthy. And for most of us, we feel much better if we're in love, but it might not necessarily be a passionate love. It might be feeling loved and cared for. And this feels relevant because an awful lot of our patients with idiopathic pulmonary fibrosis live alone. And I want to bring this to the fore because often that is something that we don't ask. People come to clinic and we don't take heed of the fact that a lot of patients are coping with this condition and they're to some extent socially isolated. I thought the little drunk bit might be contentious, but I did an internet search and found that Ireland is only second to the Czech Republic in its consumption of beer per capita. So I suspect most of us here enjoy a little tipple from time to time. So it is a privilege to be here and to be part of the Fergus Goodbody lecture. And I want to thank ILFA very much for sponsoring my attendance. ILFA play a valuable role on the international stage as a charitable organisation, providing information and support and promoting education and supporting research. And all these things are very important to the provision of palliative care. I also wanted to acknowledge that we lost today Professor Stephen Hawkins, died in the early hours of the morning, and he is someone who will continue to live on because he created such a ripple in the scientific world. And this quote is from Terry Pratchett, famous author, who again continues to ripple through the literary world with the books that he's published. And I just wanted you to all think about what your ripple effect is in the world of interstitial lung disease, either as a clinician or as a carer or as a patient. And what would you want your legacy to be, no matter how small, but I'm sure there is something that you're able to do that will make a difference. And so to palliative care with all its wonders and contentions, and it is a contentious term, it's emotionally loaded, and so I thought it useful to go back to the WHO definition, which talks about an approach. So an approach being a process is something with a degree of flexibility and not necessarily an absolute method. I think that's something that we need to bring to our palliative approaches. It's something that we should think about when we're contending with life-threatening illness, and certainly IPF is life-threatening and life-shortening. And I think we all would agree that prevention and relief of suffering is something that has laudable intent. But I'd also like us to think about the relief of suffering for clinicians. We often forget the burden that we cope with in supporting people with idiopathic pulmonary fibrosis, and we sometimes need to pay attention to clinical supervision and good mentorship. And thinking about palliative care holistically of the physical, psychosocial and spiritual impacts, we can measure that in different ways, we can have conversations about that. But I also want us to think about the holistic way in which health services work, and that we need a much more integrated approach, that we're in danger of becoming very honed in our specialism and forgetting about the wholeness of the person and forgetting to communicate with services, and therefore care is not all as streamlined as it should be. We're all familiar with this diagram. It often appears when we give talks, and I wonder if any of you have ever thought about using it as a decision aid in clinic to look at it with patients and think, we can't predict the trajectory you're going to follow. We're facing uncertainty. We imagine, given the clinical data that we have, that you quite possibly will be with us for quite some time. But at this juncture, we can't say. And so perhaps we should think about arranging a conversation with palliative care services. Possibly you don't need it, but when you do need it, when you have progressed to this stage, you know where to go. Something that can be done in a very simple way and a uniform way so that we know some of those discussions have been had early in the disease process. The assessment of needs is not just a one-off, it is an iterative process and it is dynamic. So we showed some slides depicting exacerbation, and certainly we don't know when those exacerbations are going to occur. And so everyone who is involved in the world of IPF has a degree of uncertainty to contend with. I'd also like to reiterate that uncertainty is not a problem, it's how we deal with it that can make it a problem. And sometimes uncertainty creates psychological distress, and it can compound the clarity of the thought process. But that might be a normal process, and so I'd urge you at these initial stages not to think too hard about measuring the clinical constructs of anxiety and depression, because if someone's just had a diagnosis and they're dealing with uncertainty, they're probably going through a normal process of psychological distress. One way we can initiate palliative care discussions is through measuring and monitoring. And there are a variety of tools out there. If you do a Google search, you will pick up a lot of tools. Most of them have been developed in the world of cancer, so have a strong emphasis on pain, but it can guide discussions. And it may be that we can just use the quality of life and symptom measures that we're using in clinic. And again, it's important to think of these measures not as something that's just to be used for research purposes, but it does have clinical relevance. And therefore, when you notice that a patient is declining on the symptom score, it can be a way in to have these discussions about their palliative care needs. We talk a lot about the world of cancer and IPF and similarities. And this diagram, I think, depicts it quite well. And certainly listening to Toby's talk and thinking about new novel therapies that are coming on board, we probably are going to see people following this sort of trajectory. So therefore, initiating and deciding when to have those palliative care and end-of-life discussions might become more complex. Therefore, if we think about the discussions at the outset, it does give a more streamlined approach. And we will always have those patients who surprise us and have a very poor prognosis and a rapid decline. And one of the graphs that Toby showed looked at the comparison with pancreatic cancer. So for some people with IPF, they're going to be following this trajectory, and therefore we shouldn't be waiting until this stage before we discuss optimizing end-of-life care. I was privileged to be invited along with Nicola Cassidy from ILFA to contribute to this palliative care in ILD review for the Lancet, which was launched on Palliative Care Day last year. And I can claim responsibility for the title, and I think as a group we felt very strongly that palliative care is very much about optimizing quality of life and managing symptoms effectively. But through our international conversations, we were able to identify some misperceptions around palliative care, some of which will be familiar to you, that it is synonymous with end-of-life care, that it has no role in the early course of the disease, that interventions that improve life expectancy should be prioritised. And whilst these are important and agree that they do have a priority, they shouldn't be prioritised over symptom management and maintaining and managing quality of life. And also that psychosocial needs and quality of life is secondary. And I think we've had a difficult time with IPF where the focus has been on antifibrotic treatment, and it's fantastic that we do now have these treatments available and that we can look at prolonging life. To an extent, that has taken precedence, and we have lost our focus on quality of life and symptom measures, but now they very much need to come to the fore. And I think historically, because of these misperceptions, we have had this culture of neglect, and now it's very much time to turn that around. And we need to think about these interventions and how we can simultaneously look at improving quality of life as we do in the world of cancer. We identified 11 things that people with interstitial lung disease need, and I won't go into discussing all of these. We'll talk a little bit about ILD specialists. These are things that ILFA does very well, looking at awareness raising and supporting families. And we'll focus a little bit on symptoms and oxygen and pulmonary rehabilitation. So a systematic review has just been undertaken, and it was an RFPB study, and I'm not sure if it's published yet, but I think this recording will hopefully go up after it has been published. And that was by Sabrina Bajwa et al. At King's. And they looked at 31 studies in interstitial lung disease, and so there were over 1,000 patient episodes. And pulmonary rehabilitation, I think it was 17 studies that represented. So it is an intervention that's been studied more widely in ILD compared to other interventions. But it didn't differentiate between pulmonary rehab specifically for restrictive lung disease compared to pulmonary rehab for people with obstructive lung disease. And there are some differing needs. And that's something that we found very much in work that we did around singing for breath management, that the needs of people with restrictive breathing patterns was very different to singing approaches used in COPD. And so pulmonary rehab in interstitial lung disease per se does seem to have some impact, but that impact is not sustained in terms of 6-minute walk test distance and quality of life, which is possibly what we would expect. And so we certainly do need to be thinking about doing some more work and looking at sharing our data so that we can improve the evidence for that. With regard to oxygen, there's very weak evidence around the positive impact of ambulatory oxygen. And oxygen is a completely different story when we head towards the end of life. And this is a story that was published, well, it's not a story, it's an account that was published in the Irish News recently about a gentleman with idiopathic pulmonary fibrosis. And unfortunately, when he was transferred to the nursing home, the oxygen he required for care was not available, and there has been an investigation into this case. And it's not an isolated incident. I know of 2 similar incidences in London, one exactly the same with a transfer to a nursing home, and another with a gentleman who was in a hospice, and at the weekend the person with the key to the oxygen cupboard couldn't be contacted and there was not enough oxygen available. And yes, these people were going to die anyway, but it should be a controlled and considered death. And therefore, I want us to reflect on our discharge practices and how we think about planning for oxygen needs. And I guess that goes back a step about when patients exacerbate of whether they should be in hospital or not. And how do we make those decisions when someone is rapidly deteriorating about oxygen therapy, where that is initiated, and whether the place of death should be within the hospital environment, at home or hospice or nursing home. We do now have MyEvo, which is produced by Fisher Paykel, and I think you'll probably have a lot more experience of using that in Ireland because of the way your cost system is set up. It is somewhat challenging in the UK. There's differing discussions around its value in people with idiopathic pulmonary fibrosis. I do know patients who've purchased systems, but they're not been able to use them because of the support. And so we need to think intelligently about how we guide patients through this process when they're clinging on to life and they can be making the right decisions about their oxygen equipment. So quickly to think about symptom management and how that can improve end-stage disease. It's difficult because we lack an evidence base. We tend to use low-dose opioids, oromorph, and benzodiazepines, usually lorazepam. But there is a weak evidence base around that, and so a lot of it is anecdotal and again, learning from the world of cancer. Low-dose prednisolone is contentious. I think there are those patients who do find low-dose prednisolone helpful, and therefore, should we take it away? I'm not going to answer that, but I think there are cases where patients do find they function an awful lot better. And then we lack an evidence base for the pharmacological interventions. We therefore lack an evidence base for the non-pharmacological management. There is a little bit of work from the Cambridge group around the handheld fan, and I know ILFA have been doing some further work on that as well. CBT is very effective in COPD, and again, it's an approach that's increasingly offered for patients with IPF in England. And these are just sort of sensible advice, but again, we need to think about how we can collect an evidence base for their efficacy. And then in relation to depression and anxiety, these are terms that I'm really keen to move away from. I think that we should think about psychological distress, and we should only think about anxiety and depression where clinically it is substantiated. There's a lot of work going on with using sertraline, titrating up to 100 milligrams a day to look at its positive impact on breathlessness management. I think it's a very difficult study to do because you're looking at that interrelation between anxiety and breathlessness and the anxiety-breathlessness cycle. And so I'd be interested to see some of the results of that. And increasingly I'm finding patients are using mirtazapine, and there was a small study, but I couldn't find any evidence of the efficacy of mirtazapine and the impact on breathlessness. But I think overall we would agree that good palliative care is important, and communication is key. Communication is key across all teams. Cough, I'm not going to go into. I think that's a session in itself, and exceedingly complex, and certainly measuring cough is not without its difficulties, which for those of you who have heard me speak about the IPF prom will know the battles I've had in trying to find valid measurements for cough. And so increasingly the demands on tertiary centres mean that patients perhaps are seen for their initial MDT diagnosis and they may not be reviewed for 12 months. They possibly will have input if they're participating in research. But a lot of patients then end up back in their secondary or primary care centres, and this can be where patients get lost, particularly if they do need their diagnosis confirming as they progress down their line and they were perhaps not necessarily barn or IPF at the outset, or may have been diagnosed with HP at the outset but clinically follow an IPF pathway. And so this nice standard is statement 5, that people should have access to palliative care. I think it should have been a quality statement too, because I think those discussions should take place early on after MDT diagnosis. And unless patients have been signposted at that early stage, they are very much going to feel lost and abandoned. And so this is a paper that I wrote with Newell, which is a very simple approach, a very practical paper, which is currently in press, to think about the responsibilities in community. And we think that there are 3 R's within those responsibilities: about recognising when patients are deteriorating, referring back to the tertiary centres for reassessment at the MDT or for discussion around treatment, and reviewing patients regularly. And often in the community using an interdisciplinary team approach with the GP, with the palliative care team, with the patient and the caregiver, and with the nursing team and the oxygen specialists. And thinking about how those symptoms are measured and managed and adjusted. And also thinking about revisiting the pathway of care and key anticipatory prescribing. You know, there are many patients who end up taking antifibrotics the week before they pass away, and they're dealing with side effects. And so a strong emphasis on anticipatory prescribing, but that needs to be done in the community because it's something that wouldn't happen in the tertiary centre. And Toby discussed lung transplant a little bit, and lung transplant is a treatment for people with IPF. It may be fraught with difficulties along the pathway, but it shouldn't be discounted because of its difficulties. And so these 3 R's are exceedingly important as patients are on a palliative care pathway and as they transition towards the end of life, that reassessment and that review is carried out so that treatment can be appropriate. And so how are we doing overall? Well, according to the Quality of Death Index, England, the UK and Ireland are in the top 5, but that is according to these criteria. And interestingly, within the Quality of Death Index review, there were no patients and carers involved. And so it may be that this is a good indicator for commissioners and planning services, but I think we need a little bit more of that, because clearly we are doing things well, but we're not doing things as well as we could be doing. And the people who play an important role in palliative care are the specialist nurses. And again, we have the nice quality standards that advocate people should have access to a nurse. But there are concerns that people aren't able to access nursing care, particularly in the community, despite the important role that they play, and particularly being able to signpost and support families. And so we recently published this opinion piece in Breathe, and it highlighted some of the concerns we have with the changes in the nursing profession, in view of the fact that a lot of people are retiring and we don't have the skill set coming through. And although that more nurses are being employed, often they can be posts that are just temporary for 12 months and pharma funded. And so we need to have a collaborative view of improving our approach. And so for those of you who might be interested, a date for your diary is a mentorship program that we will be running at the end of June. We have our conference as well. I'm just about on time, but I did want to mention before I close that we did some palliative care workshops in the US, and I became familiar with using this document, which is the 5 wishes, and it's essentially a living will that is used in the US, and it gives you opportunity to think about what is important to you at the end of life, and it may be worth thinking about these points to take home for yourself as an individual, even if you're a clinician, to think about how you can manage your affairs so that in the event of your demise, things are left in a tidy package for your loved ones. And if you're interested in exploring this further, we are having a World Cafe event to look at the importance of palliative care on the 9th of June, and you can contact ILFA for further information on that. Thank you very much for your attention.